over here. Now we finish off talking about MHC class 1 and 2. And now we're going to talk about number 1, in order to activate the proper cells. Again, right? The last thing we want to do, and I'll probably show you the next picture right here. The last thing we want to do when we're having a very, very bad infection is to activate cells that do not fight that infection, right? So in other words, you don't just want to activate all of your white blood cells. Why? Because it takes a lot of energy, and because if you do, you can have so many cells that are active that doesn't recognize that foreign epitope. It would be kind of useless in activating those cells, and it can hinder the activity of other white blood cells that does recognize the foreign invading pathogen, right? So what we need to do right away is 1, have recognition. So here is that macrophage. The macrophage has already swallowed up a bacterium or virus, right? It has killed it, it has processed it, and it has displayed, and it has put the epitope on its MHC class 2. And again, the epitope is that protein sugar structure coming from the virus's external capsid. What happens then is you have the macrophage displaying it, and here's a helper T cell. Notice that there is a perfect match here, right? The helper T cell has T cell receptors. So for all the billions of helper T cells that we will see, so imagine you have an infant, a 6-month-old infant, right? Or even better yet, a 3-4-month-old infant. Their immune system isn't strong yet. But the good news is that at that age, 3 to 6 months, or between 0 and 6 months, your mom's antibodies are still floating around baby. So that allows baby to really not get sick, hopefully within that time frame. So if an infant between 0 and 6 months have any fever at all, if they have a fever of a 99.8, 100 degrees, right? If you have that young of a baby, right away, it is an automatic lumbar puncture. Meaning what? Meaning that it is a spinal tap on that infant, even if there's only a very small fever. The reason why is that babies should not have any fevers because they have mom's antibodies still floating in their bloodstream. So that should resist any infections at all within the first 6 months. So we know that baby still has an infection. We know that this infection can get really bad and it can turn into meningitis. So we got to make sure then that we do a spinal tap. So then it's not meningitis, because it can cause a baby to crash and die pretty easily, right? So after the first 6 months, baby's immune system is naive to everything, right? It's never had to be functional because mom's immune system had protect the baby for the first 6 months. But after the 6 months, now baby's immune system has to pick up its job. So what it's going to do is that all of those helper T cells are naive. It has never encountered a combination of epitope or MHC2. So what happens then? So what happens is it still has a T cell receptor that recognizes specific epitope though. So what happens is these T cells, the billions of them, are already going to have T cell receptors. Each of the T cells with its individual T cell receptor are going to recognize a specific epitope. The thing is trying to find the correct helper T cell that recognizes the epitope of the viruses that are invading us right now. That's what takes so much time. We already have the T cells. We already have the B cells that recognizes all the different viruses. Now there's a mixing and matching. And that's really why it takes so long to activate. It's because you have to physically connect one cell to another, like we see here. See that? All right. It's not just a simple interaction. You need a physical match, like a lock and a key, right? When you have a lock and a key, well, you might have a key that looks very similar And that's the worst thing in the world, isn't it? Because the keys look so similar, you don't know which one's a house keys, which one's a backdoor key, which one is your, right, mom and dad's house key, right? Because they all have like a triangular shape. So you put it in, and it actually can, some keys can go into the incorrect lock. But because of the proper shape of the key, it doesn't correctly match the internal structure of the lock. So when it goes in, it doesn't turn, right? Why? Because there's not a real match. Same thing here, right? We need it to be a really correct match between the T cell receptor and the epitope MHC2 receptor combination. If there isn't that proper physical match, the helper T cell falls off, doesn't get activated, no stabilization. If there is a match, like we see here, there's a match. What happens then? There's something called co-stimulation. Co-stimulation means that you have another couple receptors, one called CD4. By the way, the CD4 is a scientific name we have for helper T cell. Some of you might have heard of a CD4 count. When somebody gets infected with HIV, they get a viral load to see how much of the virus they have. And one of the other blood tests that we test for is a clinical value for your CD4 count. It's a measurement of how many helper T cells you have. Because these CD4 are receptors specific to helper T cells. They're only found in helper T cells. So CD4 cells are helper T cells. When your CD4 count goes down, that means your helper T cell levels go down. And in HIV, and then in people with full-blown AIDS, their helper T cells are so low that sometimes it's undetectable, meaning that they can't activate any B cell, any cytotoxic T cell. They can't activate any part of their specific immunity then, which is crazy. You don't survive long like that, right? Now, these CD4 help stabilize. Besides being a receptor specific for helper T cell, it has a function. And the function is to stabilize that connection. Then you have another co-stimulation molecule, B7, from the macrophage, and CD28 from the helper T cell, right? So these co-stimulating receptors allows us to stabilize the interaction, so then when the macrophage releases cytokines, there's time for the helper T cell. There's time for the interleukin-1. Highlight that. Interleukin-1 to go from the macrophage to the helper T cell. You need all of these to happen. You need interleukin-1 to be released. You need recognition from T cell receptor to epitope MHC2 complex. Then you need co-stimulation with CD4 and CD28 and B7. All of these are required for us to activate the proper helper T cell. For the test, since you two are the only one here, I'll give you a little hint. I would not ask about these, CD28, and I would ask about CD4, right? Because CD4 is so kind of related to helper T cells, I would ask you, right? What is CD4? And CD4 are receptors found only in helper T cells. CD4 are part of our co-stimulation of the helper T cell. All right? I would ask that, CD4. What is CD, right? Now, that'll be on the next test. So I would write it down if you guys haven't already. What happens if there is recognition? So you have the macrophage, you have CD4, B7, CD28, and then this big one, interleukin-1. So highlight interleukin-1. Okay, and CD4. What happens, right? With interleukin-1 release and co-stimulation with CD4 from the helper T cell, stabilizing that interaction. Interleukin-1 goes to the interleukin receptor. And the cool thing is, the more interleukin-1 you release, the more interleukin-1 receptor the helper T cell produces. So then there's a huge stimulation of this helper T cell, right? What happens then? The helper T cell then falls off, starts forming interleukin-2, which then helps the helper T cell form clones, right? These clones all contain the same T cell receptor, all recognizing the same epitope. Perfect, right? Why is this perfect? Because the epitope is found on whatever's invading you. So when these daughter helper T cells have the same T cell receptor, it's able to recognize that same antigen, that same virus coming in, right? Some of them, helper T cells, can form even more clones. Some of them, right, will be saved as memory helper T cells. So when we think about memory cells are not just, B cells. We can see memory cells that are helper T cells, cytotoxic T cells. So now what happens? Helper T cells, right, activates. As it activates, now this is where its job in helping everything else out comes into play. Keep in mind, helper T cells does not kill anything directly, but it does activate cells that does neutralize and kill those infected cells and the virus itself. So it does kill, but not directly, right? It indirectly causes activation of cells that does the killing. And the one that does the killing is cytotoxic T cells. Cytotoxic T cells are also called CD8 cells. These cytotoxic T cells are great against intracellular microorganisms, like viruses, fungi, intracellular bacterium. Now, intracellular bacterium, whoops, come back here. Intracellular bacterium, I mean Mycobacterium tuberculei. That should be up there, not down here. All right, so it's good against all intracellular microorganisms. Viruses, fungi, Mycobacterium, which is an intracellular bacterium, parasites like malaria, things like that, is really good at destroying. So keep that in mind when we're looking at this, is that we do have the ability now to fight off infections that are internal. Because keep in mind, right? Why is it so hard to fight off an intracellular parasite? Well, number one is because it's in our cells. How are we going to have a cell that kills your infected cell, right? When it shouldn't destroy it at all, when it shouldn't touch a host cell, a self cell. Well, what happens then is this. Remember, when you have infections that are intracellular, it causes a change in our cells, MHC class 1. That's where these CD8 cells comes in, right? CD8 cells are going to be important because, it's okay, all right? They're going to kill and lyse virally infected cells. They're going to lyse tumor cells and tissue transplant cells. So these cytotoxic T cells, our NK cells, are the ones that also gives us what we call host graft rejections, tissue transplant rejections, right? They release a lysine that causes the infected cell, virally infected cell, a tumor cell, transplanted cell to die off. So these cytotoxic T cells are the ones that actually do the killing. They also produce cytokines, which promotes phagocytosis in the macrophages, and inflammation. Remember, inflammation is important when it's local. It allows us to trap any viruses, any microbe that is found at the site of the infection, right? As an antibody-mediated immunity, memory cells are produced. So we're going to see T cells, helper T cells, cytotoxic T cells are also saved up. Some of them will be saved up for future infections. Some of them will be activated and kill for that acute infection phase, right? Now, cell-mediated immunity also causes what's called delayed type hypersensitivity reactions, right? Like poison ivy when you get exposed, or even better yet, when some of you guys have been exposed to the BCG vaccine, right? Sapana, I know, where were you born, Sapana? I was born in Indonesia. So being born in Indonesia, when I moved to America, on the left arm, on my upper left arm, there's a little bit of a roundish scar. Do you have that?
Yeah, I have also.
Okay.
I'm from Nepal, and we used to have this injection when we like childhood. Yeah, they gave us vaccine.
Yep. This is called the BCG vaccine.
Yeah.
It's called the BCG vaccine, right? Now, this BCG vaccine is given to usually people from a foreign nation when they migrate to America. And in America, Americans don't have this, right? That's why you don't see Americans having this kind of same scar as we do on our left arm, right arm, sometimes even in the leg.
Right.
All right. Now, this vaccine is supposedly good for TB. The bad news is it's not very effective against TB, right? It really isn't. What it does do, though, is it does give us a little bit more immune response to other type of infections, though, right? Now, the good news is, and you know, I know in Europe, they've been thinking about giving all the European citizens this vaccine now because they think it could be helpful for the coronavirus as a cross reaction, right? So even though we have the scars, it didn't protect against TB, it might actually be okay because it might limit and mitigate some of the damage from coronavirus as a result of this, right? But with TB, TB is intracellular mycobacterium here, bacterium. And when we have a reaction, have you had a TB skin test yet?
No.
Do not, all right?
I
Now,
have.
they might make you have it first, all right? Do a TB skin test when you're doing your, you know, like clinicals, right? I assume you're gonna be in nursing, right?
Yeah.
So they will give you TB skin tests. Your TB skin test will become very positive, all right? Whereas a normal TB skin test will give you like a small lump. People in America that have not been exposed, not even a lump at all, right? For us that have the BCG vaccine, that BCG vaccine has parts of that mycobacterium as part of the vaccine. So we've been exposed to that. So I have saved memory cells from that vaccination. When we introduced the TB skin test, they put also a little bit of the mycobacterium, the bacterium as part of the TB skin test. What happens to us then? What happens is our memory T cells activate, right? And it becomes huge. The first time when you have a TB skin test, Sapana, it will be big, but not that bad. Then they'll make you do chest x-rays from that point on. At that point, do not do any more TB skin tests, all right? You can do and ask for just chest x-rays, right? The reason why is this. I got it 2 times. The first time I did TB skin test, it was big, false positive, right? I had to do chest x-rays. And then I did it again like my 3rd year of medical school, right before I did my, you know, electives. So I'm in the hospitals at this point. And I didn't just get a small lump. Mine became almost like a big black cigar burn. Huge cigar burn. It became almost like, you know, it looked like I was like shooting up and then it just became kind of, right, scarred, right? It looked ugly. So ugly that in the middle of summer, I had to wear like a long sleeve shirt under my scrub. So then mothers don't look at my arm when I'm treating their kids, right?
Yeah,
And
I have one friend. She's taking CNA training right now, and she has a large scar in her arm. Yesterday I saw and I asked her, "What is that?" And she say, "I test TB in clinical, so I have the scare here."
yeah, yeah, and you gotta be careful because hospitals will ask that you do a TB skin test. I mean, it makes sense, right? You don't expose anybody,
Well,
but we will
can't you
always
opt
have a
out
response.
and
Yes, go ahead.
can't you opt out and just
Yes.
do the blood test?
You can opt out, and you can actually, you don't even need to do blood tests. You can do a chest X-ray, right? And that should
Okay.
be enough, a chest X-ray. And that's enough. I know because I was going in to become a doctor, so I had to do something more. I had to actually take the antibiotics, right? And those antibiotics are strong. So those antibiotics can cause liver failure. So they tell you don't drink, don't do anything, all right? That can, cause damage to the liver if you're taking the antibiotics. But because of that BCG vaccine, I would never, ever do another TB skin test. I would opt out, definitely do a chest X-ray, right? But that is one of the things that we do see is that, right, we do see a high false positive, right? And because of that BCG, what happens is we had memory T cells from that vaccination. With the TB skin test, those memory T cells activate and they start fighting off what the body thinks is a full-blown bacterium. And it causes a huge inflammatory response. All right, now let's talk about cytotoxic T cells, how they activate. Again, there's specificity here. So like we see with helper T cells, cytotoxic T cells also have a receptor that also recognizes a specific epitope, right? This target cell is an infected host cell. It'd be like one of our cells that have been infected with the cold virus. It's already been infected. Because it's been infected with a virus, it's now expressing viral epitopes. And since it's a nucleated cell, it's got MHC class 1. So this is like an infected cell of your throat when you have a viral sore throat, right? Viral pharyngitis. What happens? Well, the cells of your throat becomes exposed, becomes infected with the virus. The virus takes over the machinery of that cell and it reproduces all the different proteins of the cell, including the epitopes. As it produces the proteins, we add it to our MHC class 1, and that combination of epitope, MHC class 1, then needs to be recognized. Here, our cytotoxic T cell has a T cell receptor, that matches that combination, right? As this matches a combination, what happens, right? You need co-stimulation now is CD8, right? CD8 reacts with MHC1. 8 times 1 is 8. We call this the rule of 8s. The rule of 8s is just a way of recognizing which cells reacts with which MHC molecule. So here, cytotoxic T cells, we say they are CD8 cells. Helper T cells, CD4 cells, right? So CD8 cells reacts with class 1 MHC. Where do we see class 1 MHC? Infected host cells. If there's a match right here, then the CD8 helps to co-stimulate. And here's where helper T cells comes in. Helper T cells are in the background and they release interleukin 2. This interleukin 2, right, also stimulates the cytotoxic T cell, and the cytotoxic T cell then can form clones of itself. And what happens then? Any of these clones that are fully active will have the same T cell receptor. So this cytotoxic T cell, these daughter cells, they have the same receptor, and now there's hundreds of thousands of these cells that all have the same receptor. that all recognizes the same epitope. Anytime it encounters this epitope on my cell, we know that it's an infected cell. What happens then? Well, the daughter cell can recognize that epitope displayed, and it can kill that infected cell. This is how we get rid of infected cells, is by these cytotoxic T cells, right? Having a receptor that recognizes the viral protein, the viral epitope. Once it recognizes a viral epitope, well, if this was a healthy cell, would it have that viral epitope? No, it would have my host protein sticking out, right? If it has my host protein, the T cell receptor shouldn't match. No activation. We then don't kill a healthy cell. But if we have a host cell, my cell, host means you, me, right? If we have a healthy cell, right, but now it's been infected by a virus, what happens? We start making viral proteins, those epitopes that we mentioned. So the viral protein or epitope is then displayed on MHC class 1. Before, since it was healthy, you didn't see viral epitope. You just saw a host protein, a self protein. But now, because there's an infection, you do have a viral epitope being displayed. The T cell receptor matches. Then you have co-stimulation with CD8 and interleukin 2. Then we form clones of the cytotoxic T cells. Those clones can kill any other cell that displays the same epitope. Why? Because those clones will have the identical T cell receptor. And any other cells it encounters, the many billions and trillions of cells in your body that is also infected with the same virus, will also display the same epitope. So these cells can recognize those epitopes and start killing the infected cells that display that same epitope. Now remember, you're gonna have thousands of different epitopes from a virus. So this is just one of it. So for this cell, you might even have, 1,000 more MHC class 1 with 1,000 more epitopes, differing epitopes on it, right? So then you have cells that maybe this cell isn't around, right? If this cell isn't around, it doesn't matter because you might have other cells that recognizes some of the other epitopes as well, right? So we don't just activate the one cell that recognizes one of the epitopes. You want to activate all the cells that recognizes all the different epitopes. Then you form clones of them. And then some of those epitopes will be displayed, right? And then other cells will recognize those epitopes and be destroyed by those differing cytotoxic T cells. It's kind of cool. There's so much specificity here. All right. Now, tolerance, making sure that our lymphocytes does not kill healthy cells. That's called tolerance. State of unresponsiveness of lymphocytes to a specific antigen, most commonly to self-proteins or self-antigens. Now, there are people that also, most of us, have tolerance to allergens, right? Like pollen. Pollen's an allergen, all right? Pollen should not cause issues in most of us, but in some of us, that pollen can trigger a mild immune response, causing us to have, right, stuffy nose. God forbid, if it's bad enough, causing us to have some kind of anaphylactic reaction. Right. So that's helper T cells. Now, how about B cells? B cells are gonna work very similar to what we're gonna see with a macrophage. Here's what happens. Remember, in a macrophage just swallow up a virus, kills it, and then displays it. All right, the epitopes on its MHC class 2. That's the same thing with B cells. B cells also has an MHC class 2, right? But the difference between a macrophage and a B cell is this. Macrophage swallows up a virus. It doesn't matter what virus. It can swallow up a bacterium. It doesn't matter what bacterium. So it's very general in what it does, right? For B cells, it's a little bit more specific. What do we mean, right? B cells have a receptor. That B cell receptor is also an antibody. See that? This B cell receptor is the antibody that it will produce. The only difference is this antibody that it will produce is then stuck on the B cell to make it a B cell receptor. Antibodies have specific binding sites on each arm. So on each arm right here, you have a antigen or epitope binding site. So if this virus right here has that epitope sticking out of it, let's say that is epitope A. If the B cell receptor recognizes epitope A and the virus has epitope A, then there's a binding. Once the epitope A binds to the B cell receptor, then you bring the virus inwards and you kill it. As you kill it, that same epitope A will then be displayed on MHC class 2. And only epitope A will be brought in and displayed on MHC class 2. That's the difference between a macrophage and a B cell. Macrophage just swallows up the whole virus, kills the whole virus, then displays all the epitopes on the virus on its different MHC class 2 molecules. For B cells, there's a lot more specificity. All right, if you have this epitope A on the virus, then the virus is brought inwards. If this virus does not have epitope A, there's no bringing it in. It just goes away. You don't bring it in, you don't activate this B cell. Again, why activate a cell that doesn't recognize your invading pathogen? So if there is no epitope A here on the virus, it just comes off. If there is epitope A, then that epitope binds with the receptor, the antibody, which is a physical match for epitope A. Then you bring the virus inwards and kill it. After you kill it, even though this virus might have thousands of different epitopes, you only display that one epitope that allowed you to bring it in, right? So this epitope A, there might be 1,000. You have A, B, C, D, A, B, A, C. All of those epitopes are all found as part of the virus. Doesn't matter. Only that epitope A that allowed us to bring the virus in the first place. Only that epitope is placed on MHC class 2, right? Then what happens, right? Now that combination of epitope A, MHC class 2, will then be displayed because B cells are also antigen presenting cells. It's going to display it and present it to a helper T cell. This helper T cell has a matching T cell receptor for epitope A. Then CD4 co-stimulates, interleukin 1 is released. Interleukin 1 then activates a B cell. Perfect. Actually, it should be interleukin 2, right? Activates the helper T cell is then going to, right, release interleukin, which then causes its activation. Once it activates, it forms clones, and the clones, some of them are saved as memory B cells. Some of them turn into plasma cells, and it is these plasma cells that produces an antibody. Hint, you're going to see that in the test. It is these plasma cells that produces antibodies, right? Plasma cells, not B cells, but plasma cells are the ones that produces antibody. So plasma cells are activated B cells. The antibodies that plasma cells produces all recognizes the same epitope. So here's epitope A. That's what allowed you to bring the cell in. That allowed you to bring the virus inwards. If this virus did not have epitope A, the virus just falls off. But if it did, then the epitope A allowed you to bind to the receptor, the antibody receptor. Then you're bringing the B cell you're bringing the virus into the B cell, you destroy it, and then you place epitope A onto MHC class 2, and that combination is presented to a helper T cell. The helper T cell has a T cell receptor that should match that combination of epitope A and MHC class II, along with co-stimulation by CD4 and release of interleukins. Then the B cell activates, right? As it forms clones and proliferates, some of the clones turns into memory cells. A lot more of them turns into plasma cells. And it's these plasma cells that produces the antibodies. And all of these antibodies that we produce, all of them will recognize epitope A, and that's it. Not the other 1,000 epitopes found in the virus. Only the one that allowed you to bring it in the first place. And what is an epitope? It's epitope A that allowed you to bring it in, right? So there's antibodies that are gonna tag, is gonna bind to any virus that expresses epitope A. It'll bind to it. So if you have the virus out here, free flowing in your body, and you have an antibody right here, it will then attach to the epitope A. It will tag it, neutralize it, and it'll tag it for destruction. Antibodies don't kill anything by themselves, but it does neutralize the virus. So then it can't infect other cells. It does tag it, so then it makes it easier for macrophages to find and to swallow it up and kill it. But it doesn't directly kill, right? But look how important helper T cells are. What do? Right? We saw helper T cells activate cytotoxic T cells. By activating the cytotoxic T cells, you're then killing virally infected cells. So then the virally infected cells don't produce more viruses. Helper T cells also help activate B cells. Once it activates a B cells make antibodies. Now what happens? Those antibodies will bind to the viruses that are free floating around in your body. So now we're destroying the infected cells. So then there's no more viruses being produced. And whatever viruses are still hanging around are going to be tagged with antibodies and neutralized. As they're tagged and neutralized, it also brings more macrophages to that area. So then you can swallow up and kill all those extracellular viruses floating around. Perfect, right? Exactly what we want to do. We want to kill all the viruses. We want to neutralize it so then it doesn't infect other cells. And then if it can't get in and infect other cells and they start to get eaten up by macrophage, and now we're killing the infected cells so they can't reproduce more viruses, now we're able to fight off that infection. Problem is, it takes time, a lot of time. All right. So let's take a look at antibody-mediated immunity and what this means, right? What it means is this. With antibody-mediated immunity, right, it's humoral immunity, it's antibodies, and the weird thing is we have different antibodies, right? We have IgG, IgM, IgA, IgE, IgD, lots of different antibodies. All of them will be produced by each of these cells. So this cell right here can, once it turns into plasma cell, can produce, and usually it produces IgG and IgM, right? IgM is produced first, antibody M, and all the antibodies that we're going to talk about, IgM, IgG. Those antibodies, if it's produced by this plasma cell, right, even though they're different types of antibodies, they still, though, only recognize the same epitope, epitope A. So once we have a plasma cell become active, you can produce different classes of antibodies, but the antibody will still recognize only that original epitope. That's it. They're just different class of antibodies. And here they're showing you where the binding sites are, right? And the cool thing is, I know there's a huge, and when I was auditing that class, right, we talked about the different recombinations molecularly at the variable regions and how that's all done, and it's really complex, right? But through genetic recombination, we have different antibodies that can be produced by the different plasma cells. It's kind of cool, right? So this highlighted for a reason, right? Know the difference between these. IgG, IgM, these are the most important ones to fight off an infection, right? When we're doing antibody tests to see if you've been exposed to corona, what happens then is that we're looking for the IgG. This is the most effective antibody, right? The IgM is going to be the first one produced, but it's effective, but not quite as effective as IgG. Now, immunoglobulins and antibodies are the same thing. So when you hear of immunoglobulin, it is antibodies, even though they have two different words. Just understand, we're talking about the same immune protein here. Now, what's important about IgG? Activates complement, promotes phagocytosis. These are the ones that cross a placenta and gives immune protection to the fetus or newborn. These are also the ones that can be responsible for hemolytic disease of the newborn that we talked about in chapter 19, right? And then, all right, it is also responsible for our secondary response to an infection. And we're going to see in a second what is a secondary response. IgM, often the first antibody produced in response to an antigen. Like all antibodies, it will activate complement and acts as an antigen binding protein. Right? Antigen binding protein on the surface of B cell receptors. So the antibody that we saw, I believe a couple slides ago, right here, right? That could easily be IgM. Normally it's a different one, right? It is usually IgD that's going to be the antibody, antigen binding receptor on B cells. So what do I want you to know for IgM? This is IgM right here. Look at how big it is, right? Because it's so big, it's got, remember, each arm has a binding site. Here's one arm. There's 5 different antibodies here, right? 5 of them. That means there's 10 binding sites here, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? It can bind to a lot of different viruses. Remember, each of the binding sites, though, will be specific for that epitope A that we had mentioned before. Even though it's got a lot of binding sites, the binding sites still recognize it's the same thing. But what it does allow us to do is to form, right? So what happens? If you release IgM, all right, can recognize epitope A over here. It can bind to a virus over here with epitope A. So it binds that virus right here. Then you have another arm that can bind to another virus with epitope A. What happens? You can make a big complex because you can bind a lot of viruses here, right? This complex that you form can also cause some kind of autoimmune disease that we'll talk about in a second, right? So review these antibodies and the highlighted area, right? IgA, secretion in tears, IgD, antigen binding receptor on B cells, right? Here's the action of antibodies. 1, it tags the antigen by binding us with its epitope. By binding with it, it makes it hard for that virus to go into the cell. Now, when it binds to a bacterium, which it can as well, usually the bacterium, the epitopes on the bacterium is what makes it really toxic. So by binding to that protein on the outside of the cell wall of a bacterium, you can neutralize it and inactivate it. You can also have what's these cross reactions, right? And by causing them to stick together like this, now the virus and the bacterium or the bacterium can't move. Because it can't move, they can't infect other cells. It can activate complement, causing activation. So you bind the antibody to the epitope on the antigen. That's part of our classical complement cascade, which causes activation of membrane attack complex. The membrane attack complex and punctures through the viral capsid or the bacterial cell wall, causing that to die. Right? Now, certain antibodies can attach to mast cells. And then as it attaches to mast cells, this is the one that's bad, right? That just cause inflammation and allergies. Another thing antibodies can do is tag it, right? Tag the virus, attracting more macrophages and making it easier for the macrophage to swallow up and kill the antigen. Perfect. So notice that you don't see anything, right? The antibody killing anything directly. It does that indirectly. Now this is, right, pretty interesting stuff. And then we're almost done, right? So here, we'll get through like the next few slides and some hypersensitivity one. And it's really cool. That's why I want to go through this. So what is antibody production? You might see a picture like this on our written test. Right? Now, what do you guys prefer? Would you guys prefer to do a written test that's separate or just one big test?
Separate will be fine.
What's that? Separate? Yeah,
Yeah.
I think because then it gets to be overwhelming when the test is too big, you know?
I was kind of hoping for all-in-one test just to like be able to like get it over with, but I mean, I guess I can do them separate as well, if that's what like other people are
If you're doing
preferring.
one big test, then it's like 2 hours. You know, probably give you guys about like close to 2 hours to get it done, but you can't come back to it, right? So you'd have to do it all at one time, which
I mean, I guess
think
that sounds reasonable.
Yeah, so we'll see.
Split it up.
Right? So with primary response, this is what we're seeing right now with coronavirus. Now, a better example is what happens when you get chickenpox, right? Most of you guys have gotten the vaccine, but some of you have gotten the actual illness before. So let's say you get the illness. You're, like me, moved to America when you're like 9 years old. And what happens is at 9 years old, you move to America. We've never been exposed to chickenpox. Within the first 2 months I was in America, I got chickenpox, right? So what happens? That's my first initial exposure with the real virus. Take a look at how long it takes for me to mount any immune defense. Up to 2 weeks after the initial infection. Then we start seeing a small immune response. What happens? Why does it take so long? It's because it's the first instance, the first priming event, first exposure. The virus comes in. Now we need macrophages to swallow it up, to display all the epitopes, to match and find the proper T cells, helper T cells, to find the proper B cells. So then we know which cells to activate. The cool thing is,
I'm in class right now.
Right. The cool thing is that when we're looking at this, right, the cool thing is that we are able then to, right, we already have the cells. We just can't, it just takes time to find the cells. We have them already. We just need to find them. That's why it takes so long, right? And what happens after 2 weeks? We find the proper B cells, right? Some of the B cells turn into memory cells. Some of the B cells turn into plasma cells. And then what you start seeing is this small immune response that allows us to fight off that infection, right? That small immune response then allows us to fight off that infection, right? And those memory cells are saved up. That's a big one. Are the saved memory cells.
To so many just trivial stuff that babies are immune to, and now all of a sudden you have this this
Let me see if I
infection.
can mute her.
Yeah, to anything. It's like you can't go anywhere or do anything because.
Okay, there we go. All right, there you go, Sapana. All right, so as we have those memory cells right here, the great thing about having those saved memory cells is that when you get re-exposed, so if you get chickenpox as a child, you have all these memory cells. With the memory cells, when you get a second exposure, whether your kids get chickenpox, right? Or other people's kids get chickenpox, well, we've had those same memory cells. And those, with the second exposure, yes?
I'm not able to see your slide.
Okay, so we're on that picture again. Let me see what's going on. Okay, can you see it now?
Yeah, good.
Okay, so with those saved memory cells that we have here, right? What happens is with the second exposure, we don't have to find the cells anymore. We don't have to physically find them. Those saved memory cells just become activated. And within a couple of hours to a few days, you have this huge immune response. Huge. Look at how big, look at how many more antibodies you produce. Look at how small your antibody count is with the primary response, right? So primary response is when you're finding, mixing and matching, finding the correct cells. It takes a long time. And then when you do find the cells, you don't have this, you have a pretty small response, right? That's when you get sick, right? The second exposure, we already have memory cells from the previous exposure. All we're doing is activating them. They're easier to find, easier to activate. So then it takes much shorter period of time and a much greater secondary response is seen. Much more antibodies are produced. So you might not even know you've been infected. You've been infected with chickenpox. Make no mistake about it, right? We will get reinfected with chickenpox. The thing is, with the second infection, those memory cells explode in number, they activate, and they produce so many antibodies that you don't even realize that you've been sick, right? And you've already kind of cleared the virus. Now, not only do you produce more antibodies with the secondary response, but you produce more of the more effective antibody, IgG. So not only do we produce more total antibodies, but you produce more of the effective antibodies, IgG, right here. So secondary response, now it could be also a booster shot. There's a reason why when we do the hepatitis B vaccine, right? What do we do with hepatitis B vaccination? You have one shot, giving you a primary response. Then, a couple months later, we give you a second shot. By giving you a second shot, we have a second exposure here. What happens then, right? Those memory cells that we saved, well, now it's gonna turn into more memory cells. Then a couple months later, we give you a third booster to increase the number of memory cells even more. So then if you're exposed to hepatitis B in real life, you have a lot of memory cells. And those memory cells will activate in great amounts when you've been exposed to the real thing. So then you're able to form this huge response. And hopefully you don't get infected, right? When you've been exposed to the hepatitis B, the true virus.
So it means in our whole life, we can get only one time chickenpox?
Chickenpox? Now,
yeah.
You can, right? Keep in mind, if you're healthy, you will get reinfected. Don't think you won't, right? You'll get it. You just are able to fight it off. You're able to clear those viruses before you get ill. But you will get reinfection, right? That's the thing, is you will get reinfected. That means that you've been exposed the second time, you can give it to somebody else, but you're not gonna have full symptoms because you have the antibodies, because you have the memory cells. But you have the virus inside of you for those few days, right? Before the response is seen. And you can give it to somebody else who hasn't had it, right? Now, people ask me about shingles. Shingles is different. Shingles is a reactivation of the chickenpox, right? Varicella zoster is the name of the chickenpox virus. Varicella is a chickenpox version. Zoster that's a shingles. What happens is with our ability to kind of destroy the chickenpox in our body, there's some virus that stays alive but stays dormant, right? Stays quiet in our dorsal root ganglia cells. And when you get older, when your immune system isn't as strong, right, the virus reactivates and it gives you shingles. You don't get shingles if you've never been exposed to chickenpox. So if you have like a 65-year-old person, they've never had the vaccine, somehow they didn't get chickenpox as a child, if they're exposed to shingles, right, then they will get chickenpox, not shingles. Right, acquired immunity. This is pretty interesting as well, right? So what is acquired immunity? Is our ability to fight off any kind of infection, either by a natural cause or by man-made causes, right? What do I mean? There's 4 different types I want you to know. There's active natural immunity. In other words, best example of this, chickenpox, we just talked about, right? You've been exposed to the live version of the virus, the real virus itself. Once you've been exposed, you're able to fight it off, and you produce memory B cells and memory T cells in response. And it gives you, right, hopefully lifelong protection, right? Active because you're making active memory cells. Natural because you're exposing yourself to the live vaccine, a live virus, right? So natural means live virus. Now, active artificial immunity. Active means you're forming memory T and B cells. Artificial means you're doing it through a vaccination, right? There's no reason to ever decline a vaccination. I heard that they said, like, for coronavirus, up to 30% of Americans said that they will not take the vaccine, which is just crazy. 30% is a huge number, right? So yeah, active artificial immunity is vaccination. With the vaccination, you're either giving, right, just the proteins, the epitopes from the virus, or you're taking a version of the virus without the DNA or RNA inside, just a shell, the capsid, right? Now, does the body know, does immune cells know that it's just an outer shell? No, right? If you're just giving the capsid and all of its proteins on the outside, well, our immune cells can't look inside the cell to see if there's DNA or RNA. So it assumes that it's a real virus. So when you have vaccination, your body treats it like an active infection. Because it treats it like an active infection, you will produce memory cells in response to it. The thing is, some people get pretty sick from it, right? Somebody gets sometimes even a fever from the vaccination. That fever is not from the virus. It's from our own immune system, thinking that this vaccine is a true virus. So it increases your body temperature to fight it off, right? So it's actually our body that's causing the response, causing the fever that we sometimes see with vaccination. That's a big thing. Remember, you're not going to get infected. There's no genetic material inside the vaccine. If there's no genetic material, there's no way the virus can infect the cells. There's no way the virus can reproduce inside your cell because there's no genetic material. That's the good news. Memory cells are produced. Yes.
The live version of virus means the virus inside the our cell, or what is it?
What's that?
The live version of virus mean the virus inside our body cell, or what does mean, like different between live version and death, like
absent of DNA, absent
okay.
of genetic material. That's a thing, right? If it's absent of genetic material, these all should be absent, right? Now, passive natural immunity is very, very rare, right? We only see it in a neonate because this is a kind of, natural immunity from mother to baby. That's it. It only lasts maybe up to 6 months and that's it, right? It protects baby for that long a time, but you only get what we call transient protection, right? You only get protection for that short, limited amount of time. No memory cells are ever produced from this. And basically, we're just getting mom's antibodies floating around baby's bloodstream. That's it, right? Now, passive artificial, this is a cool one. Transfer of antibodies from one immune cell to a non-immune cell. You guys have heard of anti-serum and anti-venom, right? Anti-venom specifically. Now, you guys probably watch TV shows on TLC and Discovery, and sometimes they talk about how anti-venom is more expensive than gold per ounce. It is. It's because of what it takes to make that anti-venom. So let's say we want to make anti-venom for a rattlesnake, the Eastern diamondback rattlesnake, right? Just a random rattlesnake. What happens? In order to make the anti-venom, I need to find the snake, right? Then I take the snake and I have to milk the snake and get the venom, right? That's not the end. Once we get the venom, we have to inject the venom into an animal that has a stronger immune system than us. Usually that animal is a horse. Horses don't wear boots, right? Through many generations, they become a lot more resistant to any venom. So when we inject the Eastern diamondback rattlesnake, their venom into the horse starts to produce antibodies to the venom. The antibodies will then clear the venom without causing the horse too much damage. So what we do, we inject that horse with that venom. The horse makes antibodies to the venom, anti-venom, antibody to venom, right? So what happens then? We then, after a week, we remove some of the blood from the horse, and that blood, the whole blood from the horse, should have antibodies in the plasma. So what happens? We remove it, we remove everything else but the antibodies. As we remove everything else but the antibodies, right? The antibodies by itself, that's our antivenom, right? That antivenom, though, is only specific, though, to that Eastern diamondback rattlesnake. That's it. If you get bitten, right? If you get bitten by a king cobra, well, the king cobra has a different venom. It's got different proteins sticking out of it. The antivenom for the Eastern diamondback rattlesnake, the antibodies there, don't recognize the different epitope of king cobra. So there's no cross reaction. So that antivenom is not very effective then if you've gotten bitten by a king cobra, right? That's why antivenom is so expensive. Not only do you have to milk that snake, then you have to inject the venom into a horse, then remove the blood from the horse and remove only the antibodies. That takes a lot of effort, doesn't it? Right? And not only that, the antivenom is type specific. It's only effective against the venom that it was previously exposed to. So Eastern diamondback rattlesnake venom, antivenom, only good for Eastern diamondback rattlesnakes. King cobra antivenom, only good against king cobra venom. See how that works? Right? So it becomes really specific then. Rabies is another one that we use anti-serum to, right? If you've gotten a bat bite, immediately we expect you to have rabies. And if we can't find the bat, we will start giving you anti-serum to the rabies, right? And what the anti-serum does is these are antibodies, and it's going to attach itself to the rabies virus, tag it, and neutralize it. When you have that, all we're doing is giving you the antibodies. Are you going to form any kind of memory cells? No, you don't. And because you don't form memory cells, you are only protected for that one time, and that's it, right? So let's say, you know, you gotten bitten by a bat with rabies, and you're smart enough to go to the ER immediately, tell them you've been bitten, and they automatically then will start treating you with anti-serum for rabies. The anti-serum then is antibodies to the rabies virus. Attaches itself to any rabies virus in your body. as it attaches itself, it neutralizes the rabies virus, right? So then you don't get sick from rabies. What happens then? Hopefully you're fine, right? You're perfect. You didn't get sick. But the next time you get bit by, a bat and get exposed to rabies, right? You might have to do that again because you don't make memory cells from this. So you don't have any future protection. All we're doing is introducing the antibody to that virus, and it just clears that virus for that instant, and that's it. By the way, all right, there's only been a handful of people that has ever survived rabies once they've shown signs. When you have shown signs of rabies, usually it's almost always a death sentence, right? Now, the first person in recorded history that survived rabies after being exposed and after showing signs of rabies is this person you might have heard of. Why might you have heard of her? Is because she's from Wisconsin. She's from the Milwaukee area, right? This girl, young girl at the time, was exposed to rabies by a bat bite. She didn't know, and she didn't go in to the hospital. She's from Fond du Lac, right? But she came to Medical College of Wisconsin, right? And what happened was, right? Take a look at the year, 2008. So up until 2008, from the time we have recorded history until then, nobody had ever survived rabies once they've gotten symptoms. All right. She came into the hospital with signs and symptoms of rabies. That means hallucination. That means, all right, psychosis from the rabies. That also means that you have the drooling and everything else that we see in rabies, right? Nobody had survived it at that point. So what did they do? They were desperate. They put her in a medically induced coma, right? Medically induced coma, right? And high dose dexamethasone and high doses of antivirals. Somehow she survived. She survived, but she had to learn how to walk again. She had to learn how to talk again. She had to learn how to feed herself and swallow food again, right? In other words, she survived, but she did not survive unscathed, right? So, but then she survived though. She, right, through physical therapy and occupational therapy, she was able to regain all of her functions, right? Perfect. They tried the same protocol another 5 times on patients that were also exhibiting signs. So after they did this, they call it the Milwaukee protocol, high dose dexamethasone, high dose antivirals, medically induced coma, right? They tried it, that same protocol, 5 other times on people who exhibited signs. All 5 people died, right? So it is still something that's touch and go. And that's why I always say, like, if you think you've been exposed, you gotta go in. If you're around a bat, right, look to see if you've been bitten. And if you've been bitten, you gotta go to the ER. Now there's like crazy, speculation that getting the shots of anti-serum for rabies hurts a lot. It doesn't, right? The needle's small. It's just subcutaneous injection, right? If you've ever gotten an injection for a migraine, that's subcutaneous. That's it, right? Now you need more shots just to make sure that you have enough antibodies. But it's not that painful as some people say. Much more painful to, I don't know, right? Get the actual symptoms of rabies. All right. The last thing we'll talk about are hypersensitivity reactions. There's 4 of them. Type 1 is anaphylactic reactions. These are the ones that we see in people that have peanut allergies, seafood allergies. They're becoming more and more common. When I grew up, there was never any kind of peanut allergies or anything, right? Nowadays, it seems like every other, child we know have some kind of peanut or seafood allergies. There's been a big correlation to how hygienic we've become, right? To how sterile our environment has become. And because we're no longer exposed to the bacterium, the viruses, right, the parasites that we see from many, many years ago, in some ways, it leads our immune system to be slightly more reactive than it should be. They did a study, right? And they did a study of kids in England versus kids, right, in the developing world. And what they did is actually take a study of kids in England versus kids in South Africa. And the white kids there, the Caucasian kids, right, they're both usually from Britain, right? They have very similar genetic traits. What happened? What they saw was that the kids from England, because of the culture and the hygiene, had a lot higher numbers of anaphylactic peanut and seafood allergies. The kids in South Africa, from the same population group, had much, much fewer allergies like this. So we know it's got something to do with the overall hygiene, right? Now, what happens with anaphylactic reactions? Our body overreacts, right? We have IgE antibodies that attaches itself to mast cells and basophils, and it starts to bind with allergens. In most of us, the allergen is there, doesn't bind, nothing happens, right? But people with these anaphylactic reactions, when they eat peanuts, right, some of the peanut proteins binds with these antibodies, and it causes systemic release of histamine. When you have systemic release of histamine, your blood pressure everywhere starts to drop. Because systemic release of histamine means you have massive vasodilation. And if you vasodilated all your arteries and arterioles, your blood pressure just falls off a cliff, right? All because of histamine. Now, histamine does that exact opposite in your lungs. So in your blood vessels, the smooth muscles dilate in response to histamine, causing a drop in blood pressure. In the lungs, histamine causes your bronchioles, which also contains smooth muscles, causes our bronchioles and the smooth muscles there to constrict. So two different effects from the same hormone, right, or the same chemical right here. In the blood vessels, the smooth muscles dilated. In the bronchioles, the smooth muscles constrict. Now, this is a bad response, right? Not only do you have a drop in blood pressure, but now you have increased bronchial constriction, meaning you can't get air into your lungs. So you can't breathe and you can't move blood. That's bad. So what happens, right? This is an immediate life-threatening condition. And you need to give somebody an EpiPen immediately, right? The longer you wait, the longer the response and the more likely you can die, even though you give somebody a shot of epinephrine. So the sooner you get it in, the better. What does epinephrine do? It causes the smooth muscle in the blood vessels to constrict, causing you to increase blood pressure. At the same time, right, epinephrine in the lungs causes your bronchioles to dilate, letting air in. Right? Now, when people have asthma, asthma is caused by histamine release in the bronchioles. When that happens, we give them albuterol inhalant. Albuterol is very similar to epinephrine. They're both beta adrenergic medications. The big difference between these two is this epinephrine is systemic. It goes in the bloodstream, goes everywhere in your body, including your lungs, including your blood vessels. Albuterol is, or should be, local. Because you're inhaling it, you should only see it in the lungs. It only then causes bronchioles to dilate. Now, this is also the reason why doctors tell you that if you have to do your albuterol more than 3 times a day, we need, that's not a good sign that you have control of asthma. The reason why is simple. If you do the albuterol inhalant more than 2-3 times a day, that albuterol can go systemic and act like epinephrine. It can cause your blood pressure to increase, right? Which isn't good. Type 2 hypersensitivity. reactions are where the antibodies, IgG or IgM, are actually directed at a person's own cells or blood cells, right? So where do we see these? This is seen in transfusion reactions. Type 2 reactions occur in incompatible blood transfusion reactions, causing the red blood cells we just transfused to lyse and agglutinate, forming clots. We also see type 2 in good pasture disease, right? Good pasture disease, we start attacking our own antibodies, starts attacking the basement membrane of our lung and of our kidney. So here's a picture of our kidney, right? It's a terrible picture, right? I try to blow it up, and when I blow it up, it did not look very good anymore. But what I want you to understand with this, your kidney should not look this big. It should not look this black. It's black like this because there's necrosis, right? This is a bad kidney. It's enlarged. It should be kind of like pinkish, brownish in color. That's a normal kidney. This is black, right? Meaning that, right? What happens to blood that kind of coagulates and sits there? Kind of turns black, right? So this is what happened, is that you had a lot of infarcts here. And the cells start to die here, causing it to turn black in coloration. That's not good. And it should not be this big either, right? A kidney should be the size of your fist. That's it. This looks like the size of your heart, right? Next, right, is immune complex, type 3 hypersensitivity. This is best exampled by lupus, right? So in lupus, you have, do I have a picture of lupus? No, right? So I'm gonna show you a picture of lupus in a second. Lupus is seen when you have what's called immune complexes depositing. An immune complex is when your antibodies starts attaching itself to just normal cells, and it starts floating around. As it floats around, it deposits anywhere where you have a blood vessel, which is anywhere, right? So with lupus, you get this condition right here. Make sure you guys can see it. Can you guys see that? The Google. So here's lupus right here. And I'm going to show you a picture of it in a second if my computer is going to let me. So with lupus, you have a couple telltale signs of lupus. One is, take a look at a couple things. One, right? You have this butterfly malar rash. If I take a line right down the middle of the nose, this side should look the same as that side. They're mirror images, right? That is what we call a butterfly rash right here. And it's a telltale sign of lupus. So also, take a look at what else we noticed about this. You see any guys? Not many guys, right? Every now and then you will see a man with lupus. But like in most autoimmune diseases, it's almost always women, right? And what we're going to see is that you have deposits of these immune complexes on the face, in the joints, causing pain in the joints. It can deposit anywhere, right? Now, when I was doing my 4th year ER rotation, I had a patient, an Indian, right, young lady, probably about 13 or 14. The dad's a doctor, the mom's stay-at-home mom, but she was a doctor in India. So we know that she should be pretty smart, right? But this daughter of theirs had lupus, very severe lupus. And in the process, they had immune complexes, almost forming like a clot in the brain. And she started having what felt and what was, right, multiple infarcts, multiple clots in the brain. And her mental deficits were such that she didn't even know, right, her full name. And she just, had severe mental delay, all because of lupus. So lupus can be that bad, right? Because you can deposit those immune complexes everywhere and anywhere. So the last one we'll talk about is type 4 hypersensitivity, which is, right, TB skin test. And we kind of mentioned it before, right? So with the TB skin test, you're gonna have you have a little bit of the Mycobacterium tuberculin, usually just an external cell wall and the peptidoglycans, right? Now, you're gonna put it in as part of your TB skin test, inject it subdermally, and if you've been exposed to it before, macrophages in that area will swallow up the TB mycobacterium, bring it to the lymph nodes, right, and then mobilize any memory cells. And what we get are memory cells then going to that site of injection and causing release of interferons, release of, right, powerful inflammatory agents that causes area to become really inflamed, right? And that only will occur if, one, you've been exposed to the real bacterium, or you've been exposed to the vaccine, like, right, Sapana and I was. Now, when you have this, right, and I would suggest not ever having a TB skin test again. I would never let a TB skin test touch my arm again, right? Because each exposure is worse and worse and worse. Right. Any other questions, guys? I guess that's it. I know it was a long lecture, but keep in mind, right? And because you guys are here,